Hi, I'm Blair Bigham. I'm a volunteer with the American Heart Association and the International Liaison Committee on Resuscitation, as well as a paramedic and an emergency physician. And it's my pleasure to chat to you today about our new release of the ILCOR Scientific Consensus. Dr. Ian McConaughey, a pediatric emergency consultant at Imperial College, who is the chair of the Pediatric Task Force at ILCOR, as well as Richard Aiken. He is a children's emergency medicine specialist at Starship Children's Hospital in Auckland, New Zealand. First of all, let me get right to the point and ask, what have you guys been up to for the last 5 years in order to get this publication ready?
Looking at systematic reviews on PCOSTs, new PCOSTs that we've put together. And in the meantime, we've also introduced other review type of systems. So we've got scoping reviews and evidence update reviews. And I should explain that this particular iteration of the ILCOR Pediatric Life Support covers not just 2019-2020, but goes right the way back to 2010 and beyond, looking at previous PCOSTs, because there was a danger that they were going to be out of touch. So we use scoping reviews, which, just to elaborate on, are ways of doing a systematic search, but not actually concluding on the search itself, but simply seeing what there is. And then evidence updates, which are more limited in their scope, but it means then we could do a whole range of different questions. And I'll leave Richard to talk about what we actually sort of covered in the past 5 years.
Ian, I've heard a lot of people talking about these scoping reviews. I'm used to sort of the traditional systematic review and meta-analysis that have sort of been the centerpiece of ILCOR reviews in the past. Can you give me an example of what type of question a scoping review might be chosen for?
You might want to look at something that you are not so sure about how much there is, but you've had a previous systematic review. For example, vasoactive drugs for septic shock was one that we did. So this is an old chestnut, and we came up with just actually looking at dopamine and adrenaline, but we were keen to see if there'd been any other studies as well. But by that means, we found out what limited information there was. So that was a scoping review. The evidence update was very exciting because we involved not just members of the Pediatric Task Force, but also expert collaborators and members of the writing groups for different resuscitation councils. So we extended our range, as it were, of expertise by the evidence updates. The use of the evidence update is to just have a rough idea about what there is. Neither the scoping review or the evidence update could change any of the recommendations. So the previous recommendations were included in the publication so the reader can understand what's going on.
Yeah, Richard, you guys looked at 54 topics. That's an astounding amount of work. We certainly don't have time to go through all of them, but if you were to pick a couple to throw on the front page of a newspaper or to shout from the rooftop of a mountain, what were some of your favorites or most impactful that you can talk about?
So there's been a broad scope of the work, and as you mentioned, 54 different topics covered over this time period. And our task force has been interested in not only CPR and the immediate aspects of resuscitation from cardiac arrest, but also pre-arrest and post-arrest care. So avoiding cardiac arrest is dear to the hearts of most people working with children because that's where we think a lot of the value lies. And so we've been reviewing fluid administration in septic shock and also in trauma. Unfortunately, we're bedeviled by the low certainty of the evidence available for us. And most of us working in this sort of field tend to be extrapolating from young adults and adults to our practice in small children, which is not ideal. So our work has identified significant gaps in knowledge, particularly around resuscitation of children in traumatic cardiac arrest and pre-arrest states. And we're also seeking to improve the care of children with septic shock, which is an international problem in wide range of settings, from limited resource settings to sophisticated intensive care units around the world. If you ask me what I think the highlights are, I think in resuscitation itself, we continue to cut back to what's really important and what really works. So we're removing some of the minor details around how you perform CPR to focus on lack of interruption to compressions, achieving adequate depth, push on the middle of the chest rather than doing any attempted detailed measurements on location of hands on the chest. We continue to promote the very early use of epinephrine for children with non-shockable cardiac arrest conditions. This has been a topic of strong interest in adult arrest circles, with some concern about whether epinephrine is of value, whether it creates survivors with greater morbidity at the expense of, a relatively tiny advantage. However, for pediatrics, the limited evidence we have, which, as I've mentioned, is of really quite low certainty, suggests that if you recognize the child's in arrest and they have a non-shockable condition, give your epinephrine as early as possible. Prognostication is an ongoing concern. We have very poor ability to predict the outcome of children in cardiac arrest. Historically, there's been a sense of futility. I think we moved beyond that, and we do know that we get good survivors, but it's very hard to predict which of the children are going to have good neurological survival. And we're continuing to focus on intra-arrest and post-arrest prognostication features, because I think that would have a really strong impact on our practice. I mean, none of us want to create survivors in a terrible, burdensome, low quality existence, but we also, none of us want to throw away the chance for good survival in those children who can achieve it. We've looked at some of the post-arrest care. The targeted temperature management was a major review that I was part of. It does seem that by far the most important thing is avoiding fever rather than achieving a particular temperature target. There's some ongoing dispute about whether targeting normothermia might allow more febrile events to occur as opposed to targeting hypothermia.
Richard, you had mentioned that sometimes you're faced with maybe higher quality evidence from the adult world or evidence from different resource settings. How does the committee as a process go through and weigh, maybe a methodologically weaker pediatric study with indirect study that was higher quality but in the adult population? What's the process of that? And Ian, feel free to jump in as well. Yep. What do those task force discussions look like?
So our evidence reviews, whether they're systematic reviews or scoping and evidence updates, tend to have their search criteria based on pediatric cases. And so we generally don't consider mannequin or animal studies. And where adult data is looked at, it's where there are pediatric subsets of data available within those studies. So what we're left with often is a literature search that produces relatively few papers with pediatric information included. That will be worked through for bias and the grade process to come up with our view of the meaning of that literature, but then there's a process around the table where we add our values and preferences, and we have a broad range of people working in a wide range of countries around the world in different settings, and we all bring our lens to what this data really means in practice, and our knowledge of the adult recommendations and literature. And so those may actually influence the wording of the recommendations that we make. We also have dialogue with the adult task forces who are examining the same or overlapping questions, and some of those questions are done conjointly with the adult task force.
Ian, how do you reconcile some of the strong challenges of trying to come up with a single recommendation when you're covering perhaps very young children or infants, 17-year-olds, 16-year-olds who could be arguably considered adults all over the world on 7 continents?
So that's a really good point. So you have to think about the information that you've got and how it applies practically. One of the things that the CoSTR does, the consensus of science, as you know, which is to look at the evidence and then from there shape an expert opinion on it, is to use the expertise within the group. What actually does it mean? So, for example, as I think you just touched on, there isn't going to be resource in some countries to do ECPR for children. Out of hospital CPR in the UK would be very difficult to do as a matter of course. So we will put in caveats that the recommendations must fit in to fit the resources and that there are sustainable systems, because otherwise it's just pie in the sky and actually doesn't allow benefit at all, because we're trying to make recommendations within certain healthcare systems, but recognizing that it's up to them to say, yes, we can, this is beneficial to our population or not. So it's not sort of diktat that you must do. It's simply saying, this is what people think, but adapt it, take it to what you need. And I was going to say, that's one of the great things about this process as a whole, because the task force people are volunteers and they dedicate hundreds of hours to picking through. And we do have some quite exciting discussions, though we haven't yet come to physical blow, but there's certainly good, robust intellectual debate that goes on. The other thing I have to say at the same time is that we couldn't do all this work without the support of the administrative task, and they often bend over backwards to provide that support and help. So there's quite a big network of people, as I mentioned, and Richard, maybe you want to talk about this, the way we have extended to collaborative experts, to the writing groups and so on. Other groups do have quite large sort of associated members, and I think that's the way forward to try and get more expertise in, more help, because the number of questions that are coming forwards are increasing every year, year on year. But Richard, maybe you want to say something about that.
To echo some of Ian's comments, I do think that we have an ambition to improve the outcomes for children internationally in a wide range of settings. And in fact, some of the greatest morbidity and mortality occurs in countries with very limited healthcare resources. A lot of our task force members work in those environments, at least part-time in various aid projects as volunteers. I have to say, in some of those settings, CPR is really of passing relevance. You know, if in my personal experience in Kiribati, ICU does not exist. Hospital-based care for children is of limited resources. And so the money is going to be in prevention of, you know, septic shock arrest, in effective early management of trauma, in things that prevent you needing that ICU level care if we can possibly achieve it. And so that has influenced our task force's choice of topics. So we obviously want to cover the core resuscitation topics, but we also want to expand a little bit outside that into the pre-arrest setting, and particularly interventions which can occur in the field in resource-limited settings. You know, you can be in a resource-limited setting in the USA or New Zealand as much as some other places if you happen to live in a geographically isolated part of the country as well. So I think all of that stuff is prominent in our minds. We have had some interactions with the WHO and looking at buddying up with some of the work they've been doing on looking at recommendations for those international settings, and using some of the expertise, people who are working full-time in those environments and have a broad public health perspective as well.
It sounds like a lot of work and complicated work. Why do we have so many volunteers at ILCOR who are doing this? Do you have a sense of where their passion and energy comes from? I know it can be very, very frustrating when you're trying to look at all these very different data sets and trying to come up with
Yeah.
an answer that will really save lives around the world. Why do people do it?
I think Ian should answer this as well, but for myself, it's intellectually challenging, the rigor of the scientific reviews. Working in a small country where there are very few people in my specialty, having the peer group to have these discussions with on an international basis is invigorating and very enjoyable. We have had face-to-face meetings where you do make friends and support each other. And I think we all feel that the work is of significant value, and that's what really drives you.
Yeah.
Ian.
No, I agree. It's some of the best CPD you can have, and you've got to be on the ball as well, because there's a lot happening. And again, with evidence-based medicine, as you know, Blair, things are changing the whole time. We've gone from what used to be a simple PubMed search, maybe cardiac arrest and something, to now extensive searching, extensive assessment with grade, with bias, and the world has changed enormously. You can see that in some of the older questions that we looked at in 2010 to 2015. So I absolutely agree. It's intellectually very stimulating. Yeah, meeting and making friends around the world is absolutely fantastic. And I think there is something else that when you see in the guidelines something that you've worked on that may have influenced that, and that's on a national or world basis, then you really think, wow, as a team, collectively, we've done this. And there's a responsibility with that, but there's also a, wow, this is really important. So that's why people like it. Also, as you know, Blair, pediatricians are very nice people.
They certainly are. And I've made some wonderful friends at ILCOR, and even being a junior person on the team, it's been wonderful to have that connection with people all around the world as we try to advance the science and get more people to survive their cardiac arrest or their pre-arrest illness. And I'm very interested in how we've included more and more topics over time. It's not just cardiac arrest, it is septic shock, pre-arrest states, post-arrest prognostication. And so this is, I totally agree, very important work. And so with those regards, what very important things arose during the last cycle, the last 5 years? Anything that sort of surprised you or that you think should be a priority for dissemination?
There are two things. The first one is sepsis, and the sepsis guidance that came out that we had to accommodate within the Finnish CoSTR to recognise them. Because what's really important to our audience, because it could be any healthcare worker or non-healthcare worker in the world who will look at these, and they have to be credible. So if you don't take note of something that's come, even at the last moment, then the guidance will not appear to be credible. And that's really, really important.
I think the work of the Pediatric Task Force set us up quite nicely for giving recommendations, excuse me, about pediatric resuscitation during the current pandemic.
Yeah.
There has been a move that we're all aware of towards compression-only CPR in general because of a perceived reluctance to provide mouth-to-mouth, and this is pre-COVID. And quite a temptation, I guess, to generalize that to children. So you have one system across the board, particularly in pre-hospital care and lay training. However, it is clear from the data that we have, with obvious writers about some uncertainties about this being registry data, that ventilation remains important for good quality survival in children. And so when we're talking about modifications to CPR for children in the current context of a COVID epidemic, clearly people will be highly anxious about giving mouth-to-mouth to a stranger, and should be in a situation where there's a lot of community spread. However, a lot of pediatric cardiac arrest occurs in a home setting, where the family members know their child. They have exactly the same COVID risk profile as the child. And we would strongly promote mouth-to-mouth training for children who are at risk, like ex-premature babies, children with known conditions predisposing to arrest in the home. We continue to strongly promote ventilation and the training for people and delivery of that resuscitation. So if we didn't have that work, we might have defaulted to, you know, the easy thing is just decompressions only for everyone.
Yeah, it's been very interesting to see how the uncertainty and the fears around COVID have really driven, at times, I think, irrational or at least not evidence-based care. And having that evidence that breathing really does matter in the resuscitation of a pulseless child has certainly gone a long way. I just want to ask, what comes next now that we have these new guidances out? What's next for ILCOR and what's next for the councils, and where do we go from here?
Prioritising our peak costs, again, on the basis of the scoping reviews, and from the evidence updates, we're then going to go on to have scoping reviews for those where it seems that there is new evidence. I think also we've got to be able to be responsive, as we have been with COVID and with the sepsis guidance, because there'll always be things that come out of left field that we have to react to, and we need to be flexible enough to do that as well. There's going to be a bit of a change in terms of Pediatric Task Force membership, in that there will be a rotation off of people who may have the opportunity to come back later on, which I think will lead to this more extended network of experts.
All of the topics which have had formal search strategies defined for them in the last 5 years, and now those searches are being rerun on a regular basis and reported out to us as chair and vice chair of the task force committee, so that we can, new papers come up in particular topic areas, and so that we can keep an overview and reprioritize topics for a systematic review or another look when new data is starting to become available. So I guess it's a more reproducible and transparent approach to what we've been doing in the past, where we've sort of relied on people to put their hand up and say, have you heard about this paper, or these type of things. So I think that's a good step forward. Yeah.
Good. Sounds like we're getting more rigorous in our pursuit of scientific truth.
Yeah.
Dr. Richard Aiken joining me from Auckland, New Zealand. Dr. Ian McConaughey joining me from Imperial College in London, the Vice Chair and Chair of ILCOR's Pediatric Task Force. Thank you so much for your time and for joining me. Thanks very much.
Thanks for the opportunity. Yeah.
Thank you, Blair.